Welcome to Healthy Lifestyle Conversations with Dr. Keith Newby Sr. Welcome back, Dr. Newby. Welcome
Thank you.
back.
Thank you
Good to
very
see you
much.
again.
You
So,
as
good
well.
evening. I am Constance Davis, the 18th National President of Legim Incorporated. I want to welcome and thank you all, our distinguished speaker, members, and guests, for taking time out to join us tonight. Let me share a little information about who we are. Les Gems, meaning the jewels, in French, was founded in September 1955 in Norfolk, Virginia. We are an incorporated 501c3 organization organized exclusively for charitable, educational, civic, and cultural purposes. We are committed to promoting positive influences within local communities, and we are an affiliate organization of the National Council of Negro Women. Les Gems Incorporated has 18 chapters located across the United States. Healthy Lifestyles is one of the 6 initiatives of our Dream Initiative national program. Our goal is to provide awareness to individuals and families on the activities and habits needed to live a healthy lifestyle. More information can be obtained about LEGIM and our Dream Initiative programs at www.legim1955.org. You'll see that in the chat. At this time, I'd like to remind you that questions will be taken by our presenter. You can wait until the end or ask them intermittently. But when you are called on to ask your question, we ask that you unmute yourself and turn on your camera. You may also ask your questions in the chat box. We are broadcasting this presentation live on our YouTube channel. Now, at this time, I will introduce to you the co-chair of the Healthy Lifestyle Dream Initiative and 16th past national president of Les Gems Incorporated, Melvina Herbert.
Good evening.
Good evening.
It's good to see everybody, and thank you all for coming on. Dr. Newby, I am so glad you were able to come back to us this year. I don't know if Lisa told you, but I had a heart attack this summer.
Well, I'm glad you're okay.
Yeah, I'm doing fine. Thank you.
Good.
Thank you.
Wonderful.
But ladies and guests, we have some people probably who do not belong to Les Gems that are watching as well. I want to give you just the brief information on Dr. Newby's biography. It is quite extensive, so I'm going to try to cut it down some, but I want you to know he's a very busy man. Dr. Newby is a native of Norfolk, Virginia, where he attended Maury High School. He graduated from Norfolk State University, where he majored in biology and minored in music before earning his medical degree from Eastern Virginia Medical School. He completed his internship and residency at Emory University in Atlanta, Georgia, and then served as a fellow in cardiology at Duke University with an emphasis in clinical cardiac electrophysiology. Dr. Newby currently practices with Bon Secure Cardiology Medical Group. He also serves as Market Director of Community Health Improvement and Engagement for Bon Secure, where his primary role is to aid in the development of programs that address conditions that disproportionately affect under-resourced and underrepresented communities, with a specific focus on the Black and Brown communities in Hampton Roads and Northeast North Carolina. Through these initiatives, He strives to improve access to both physical and mental health care, promote higher COVID-19 vaccination rates among those populations with lower inoculation rates, address food insecurities, and encourage better overall health through education and community engagement. Dr. Newby is a devout Christian and serves as a deacon at the First Historic Baptist Church in Norfolk. He is a proud member of Omega Psi Fraternity Incorporated. He is married to his lovely wife, Peggy, and is the proud father of Nicole, Heath Jr., and Marcella. He is a compassionate and committed physician, a pioneer and visionary with a strong sense of community spirit, and a man with a strong faith in God, whom he credits for all his success. Yes, Dr. Newby.
Thank you very much. I was sitting here struggling, trying to figure out how to get my slides to work right. So, so forgive me for a second as I'm trying to get that right. But I appreciate everybody coming in tonight and taking time out to hear my presentation. A lot of what I try to do is, one of the things with medicine and just heart type problems is trying to sort out how do you present information in a way that people will understand and really try to comprehend and really be able to relate to this information. So I try my best to present it in a way that A, makes sense, B, things that you can relate to on a day-to-day basis. Because a lot of times if you understand the problems, if you understand the kind of premise of why things occur, and you really can take that in and understand it, it'll help you in terms of guiding your care and really buying in. A lot of times docs will sit there and tell people, just go take this medicine, but we don't actually go into the whys. Why is it important that we control this particular risk factor or this particular condition you have? What are the pros and cons, risk benefits, so that we can ultimately, guide you, and hopefully if you have buy-in and you understand why you're doing it and you fully can embrace it, that will allow you the opportunity to really say, okay, I'm going to do what's necessary to live longer and a better life. So that's essentially what I try my best to do. Now, I'm not always perfect, so bear with me as we go through this presentation. I don't know if these slides are going to work right, but we're going to try and see what we can do. So I'm going to see if I can share my screen, and I'm going to pull up this presentation. Hopefully you can see everything. Well, the biggest thing I'm running into is trying to figure out how to get it to a full screen. For some reason, it's not letting me do it. I had it at first, but maybe I'm not as smart as I thought I was. But, I had it up full screen at first, but for some reason, it's not letting me see it. But that's okay. We'll get through it. But you can see the screen currently, correct? Okay. So what I'm going to do today, we're going to talk a little bit about heart disease and really diagnosis and treatment. So what I want to do is, and again, I apologize for not having it totally full screen. For some reason, it keeps going into this mode and not the full screen. I was trying different buttons while we were talking, but for some reason, it's just not letting me do it. So I'm going to ask you to bear with me on that, and maybe it'll let me. Nah, it's not going to let me do it here either. But in any event, we can go work with this, and we'll just go through it the best we can. So what I'm going to talk about today is we're going to define heart disease. What is it? What is it all about? What are some statistics that I think you need to know? We're going to talk about these contributing risk factors. So we're going to focus a little bit on what causes heart problems. To me, if we can actually identify those conditions which prevail and create the misery that leads to heart problems, we can then hopefully help stamp out the problem before it ever exists. And that's essentially what I'm trying to do here with this presentation, is to tell you how do you develop heart problems, what are the things and conditions that lead to heart problems, and hopefully we can help prevent it before we have to worry about treating it. So that's essentially what we're going to try to do today. So having said that, what is heart disease? Well, essentially, heart disease is anything that affects the heart or the great vessels. So we have coronary artery disease, we have congestive heart failure, we have valvular heart disease, and arrhythmias. So what I try to tell people is look at it like how you would look at a house. In your house, you have your floors, your ceilings, your walls. You have rooms that go and doors that go from room to room. You have your plumbing and you have your electrical circuits. Well, look at the heart is kind of similar. Essentially what you have, your foundation, the house itself is like your heart. So in your house, you have doors that open and close. Those are like heart valves that allow blood to flow from one room to the next, essentially, or one chamber in the heart to the next chamber. So those doors have to be able to fully open and close. So think about if you have a scenario where, say, you have a door that won't open or close right. Say if it doesn't open right, you try to open it and it won't open fully. That's like a stenotic heart valve. So that valve doesn't allow full flow of blood to freely go from one room or one chamber to the next. So that would be a form of valvular heart disease. Look at it as if that door won't close. So you think about a door that's leading outside. If you have a door that won't close right, you're going to feel draft as that air flowing through. Look at it as the same as with the heart. If you have valvular heart problems and the heart valves don't close right, the blood won't flow freely from one room to the next. It's going to be going back and forth because that door is not closing completely. Look at coronary artery disease as, like, say you have a plumbing problem. So if you think about if you have plumbing in your house, you want a free flow of water. So when you turn on your faucet, you have free flow of water coming out. So if they look at it as if you have a partially clogged pipe, much like a partially clogged coronary artery, if you're only getting some water down that pipe because the faucet, only water drips out, depending on how bad that pipe is blocked, says how much water will come out. So look at a heart attack as if you have a complete blockage of a pipe. So you cut on the faucet, nothing comes out. That's like what a heart attack would represent. If we look at heart failure, that's like if there's a structural problem. So you think about you have a faulty foundation in your home, or the walls, in the house, or say water is leaking in. So then the house itself becomes faulty because of some structural abnormality. That's like what we call congestive heart failure. And then finally, you think about an arrhythmia is like an electrical problem. So if you flip a light switch on, you expect the lights to cut on. But say you had a scenario where you have, you flip the lights on and the lights flicker. That's like fluorescent lights do before they come on. That could be considered like a heart rhythm problem. So when you think about it from that context, you have these different categories. Some people will interchangeably use, like they'll say somebody had like a cardiac arrest, they'll call that a heart attack, but they're not the same thing. A cardiac arrest, it would be considered a heart rhythm problem that's not consistent with life. If you hear the term ventricular tachycardia or ventricular fibrillation, that's when the bottom chamber of the heart will not pump adequately because of electrical abnormalities. So that's different from a heart attack, which is a plumbing problem, but you can develop a heart rhythm problem as a result of a plumbing problem. So there is some overlap, but essentially they are separate entities that kind of create how the heart, your heart or how your house functions appropriately. So look at it like that, and I think that'll help kind of gel some of this together as we move it forward. So what are some statistics? Why is this even irrelevant? Well, heart disease is still the #1 killer in this country. About 610,000 people die of heart disease in the United States every year. That's 1 in 4 deaths. And it's still the leading cause of death for both men and women. And more than half of deaths due to heart disease in 2009 were in men. So they update every 10 or 15 years, you'll see updated statistics, but heart disease remains the #1 killer, is even greater than COVID. So I know a lot of people thought that was tremendous impact, but when you think about the number of people that have heart problems, you just don't, they're just not televised like you see with COVID, but they are, and they do supersede even during the height of COVID. Heart disease still was #1. So, and then you look at coronary heart disease, which is coronary artery disease, killing over 370,000 people annually. So over half of those deaths that we saw were from coronary disease or heart attacks. So it gives you some context of why we say this is such an important thing. Now, I know this structure here may look a little small, but if you look at this, these little red lines here, these are called coronary arteries. So these are those pipes, like water pipes, that fit on the surface of the heart. So that's how the blood gets oxygenated, or the heart gets oxygenated. Blood is through these coronary arteries. So every muscle in your body needs oxygen to function. And we're carbon molecules, and we need carbon and oxygen. And the red blood cells transmit oxygen through the red blood cells. So that's how we get oxygenated blood, is through coronary arteries. So when you talk about cutting off that food supply to an area of the heart, that area of the heart is going to become damaged. When you hear the term stroke, when you say heart disease, that's anything that affects the heart of the great vessel. So a stroke is a form of heart disease because the arteries that supply blood to the brain come and originate from the heart. So when you hear the term stroke, that's like a problem with a blockage of blood flow going to the brain. Brain can't get oxygen to the blood, eventually would die off, which is why you see residuals from strokes. Same thing with heart attacks. Why is this important? Because if you think about it, in order to have that tissue not die off, you have to reestablish adequate blood flow. So when we try to get people to come to the hospital quickly when they have heart attacks or strokes, we're trying to do that so we can reestablish good blood flow. Because if we can open up those arteries and get blood flow back to the heart or the brain or wherever is compromised, we can oftentimes save that tissue, and that won't lead to long-term problems. Because again, when we talk about that overlap of information, when I say there was a lot of overlap with heart failure and coronary disease, where if you kill off tissue in the heart, it eventually becomes non-functional. And that's like what I was talking about with the heart, in your house structure, if there was a problem with the foundation or something with the walls. Look at a heart attack as causing a problem with that wall. So if it can't function well, it's going to lead to heart failure-like symptoms. So I wanted to bring that up just so you see there is overlap, but I want you to see kind of how the structure of the arteries look. This thing right here is called a heart valve. So it's like that door that opens and closes. So these are just different chambers in the heart, and that's how that functions. So I want to spend a fair amount of time on risk factors because this ultimately leads to heart disease. So when you hear the term, and the reason why I bring this up on this particular venue is, why is this important? Well, these are disease processes that affect our people and our population more so. Think about diabetics. How many people on this, or even on this call, are diabetic? How many people have high blood pressure? How many people have high cholesterol levels? And a lot of times, I get fussed at just like everybody else. I get fussed at by patients because we're trying to add medicines to the plate. But we do that because if we can control these factors, we can actually help prevent heart problems from occurring. You think about, why is diabetes important? Well, what is diabetes? Well, that's a problem with blood sugar being too high. Why is that an issue? If you're diabetic and your blood sugars run too high too long, that creates some chemical reactions that will create something called oxygen-free radicals. Those oxygen-free radicals can damage the inside of vessels of your body and can lead to complications such as stroke, kidney failure, heart attack. So, when you think about, the premise of all this, if we can control the risk factors, we can control the complications that occur. What I run into, and what most doctors run into, is when you think about it, most of these diseases are not symptomatic. Most people who have diabetes do not have symptoms unless their blood sugar is either very high or very low. So you can have a blood sugar of 250 and 300 and feel totally fine. And why is that relevant? Because if you think about it, if you have a disease process that you do not feel bad about, say, like example, your blood sugar is 300, but you generally feel fine. If your blood pressure is high, say it's 180 over 100, but you generally feel fine. And I have a lot of patients that do. Think about it. Will you be apt to take a medicine every day for something you don't feel? You think about, if you have an infection, say you have a pneumonia or urinary tract infection, you feel lousy, febrile, you get chills, you're going to do whatever it takes to get better. So if somebody gives you an antibiotic you're going to take it. Now, let's talk a little bit more. Say you're on that antibiotic and they give it to you for 10 days. Say by day 5, you feel back to normal. Will you continue to take that antibiotic for the rest of those 5 days? I guarantee you, even people may say on this call, yes, but I'm going to tell you, I'm a doc. I see this all the time where they'll say yes, but they don't do it. Because once you start feeling better, it takes away the onus of why you were taking it in the first place. And that's the trouble we run into, is trying to help people to see and to understand that if you are diabetic, you have high blood pressure, you have high cholesterol level, and you do not take the appropriate medication or make the appropriate lifestyle changes that will help you, that's going to put you at risk for these heart disease processes that I talked to you about earlier. So, these are the things that I want to make sure I brought up and emphasized to you. Diabetics, need to make sure that you're eating appropriately, that you're not deviating off the beaten path, that you're exercising appropriately. We'll talk about that in a minute. If you smoke, you need to stop, because tobacco use can lead to coronary disease, which can lead to heart attack, vascular disease, because that's why people get their legs cut off sometimes, because they have vascular problems that arise from tobacco use. If you think about the 2 biggest risk factors for people having peripheral vascular disease or blockages in the leg arteries, is diabetes and tobacco use. So you see how there's so much overlap and how one thing can lead to the other. So if you have multiple conditions that can ultimately lead to a heart problem, and you have more than one, say you have 2 or 3 of these, that's going to double, triple, and quadruple your risk to develop heart problems in the future. When we talk about hypertension, and I'll get into definitions in a minute in terms of those levels you need to hear about, but just to get through this particular slide, those with a family history of heart disease. Now, when we say family history in our world, we're talking about premature coronary disease. Men, if men who have family members less than 55 that have had a heart attack, or women who've had less than 65 who had heart attacks, those are the people we're talking about that puts you at a genetic predisposition. If your grandfather had heart problems at 80, that's not truly a family history. It is, but not premature, that puts you at risk. We're looking at first degree relatives, mother, father, brother, sister, versus secondary relatives or distant cousins. That's not going to be relevant to your relative risk if it's your grandfather and he was older than 55. Really it's first degree relatives, just so you're clear and you understand that piece. If your cholesterol levels are high, that puts you at risk. If you're physically inactive and you're overweight or obese, that's an independent risk factor for heart problems. So, and I wanted to focus on this slide for a minute because I want you to really understand the premise of how we have to assign risk. You come to see us and you say you have a chest pain, we have to decide what's your risk that you actually truly have a heart problem, because we can't do heart catheterizations on everybody, and we wouldn't want to. But you have to carefully choose based on risk factors, what's the likelihood this person has heart disease? And that's really pretty much how we do this. So let's talk a little bit about hypertension. And this is the slide that gets everybody's gourd, because when they see this, they're like, man, I mean, that's a problem. Well, optimal blood pressure is if you're less than 120 over 80, that's an optimal blood pressure. If your pressure is 120 to 129, that is considered an elevated blood pressure. So, and I know people are probably like, what? I thought that was normal. It's not normal. It's an elevated blood pressure. Stage 1 hypertension is if your top number is between 130 and 139, or your bottom number is between 80 and 89. So it could be either or. If you have a pressure of 118 over 84, that is considered stage 1 hypertension. If your pressure is 130 over 60, that is considered stage 1 hypertension. So it's either or. Stage 2 hypertension is if your top number is greater than 140 or your bottom number is greater than 90. That's considered stage 2 hypertension. And that's the relative risk is that the more or the higher your blood pressures, the higher your risk for complications. So I want to really emphasize that optimal blood pressure is less than 120/80. That is an optimal blood pressure. So I wanted to make sure you understand that. Now, just because your pressure is 122, that doesn't mean you need treatment for hypertension. Normally we're going to, and I'll talk to you about this in a minute, that's a lifestyle thing we usually attack first. But I wanted to make sure you heard this from me, definitions of hypertension. Now, when you hear the term systolic and diastolic hypertension, systolic is the top number, diastolic is the bottom number. Each one can be independent and be an independent risk for heart attack and stroke. So what do I mean by that? A lot of people ask me, well, which number is more important, the top number or the bottom number? Both of them are equally important. So don't let anybody tell you different. Both numbers have potential to create a problem depending on what they are. So the higher the number, the worse the problem. So if your bottom number is always 90 plus or better, that's stage 2 hypertension, that can independently increase your risk, as if your top number is 140, your bottom number is normal. Either one of those can independently increase your risk of heart attack and stroke. Now, when we see people, and this is something that I think it will be good for you guys to know. So when we look at hypertension, how are we supposed to treat it? Now, I'm not saying what happens in the practices you go to, but how we're supposed to treat it is the first thing when you have somebody comes to your office and the pressures are high. You want to first eliminate white coat syndrome. And what is white coat syndrome? That's when you see the white coat and people's blood pressure will go up, which we do see a lot. So, so I never overreact when somebody comes to the office and the pressures are high, because I do know the potential that they could just be nervous coming to see me. I'm a heart guy. So, who wants to come see a heart specialist? And I get it. So I don't ever take that personal. I look at it as that's the nature of the beast in my field. But I can't overreact, because if somebody's pressures are high just because they come to see me, and I start adding a bunch of medicine on board, and say if they're at home and their pressures are typically normal, and then they take a blood pressure pill on top of that, I can drop your pressure too low, which is just as bad as I leave it too high. So you don't want to overtreat a blood pressure, and you don't want to undertreat it either. But the first thing you want to do is eliminate white coat syndrome. So I always encourage people to either purchase, obtain, borrow somebody else's automatic blood pressure machine. And I do get people that ask me, are those things accurate? Well, yes, they are. If you put them on right and you use them right, yes, they are very accurate. And I encourage it, because that gives me an opportunity to see what are your blood pressures running outside of just being in the office. So that's the first thing you want to do, is eliminate white coat syndrome. The second thing you want to do is you want to assess what's the person's 10-year cardiovascular risk assessment. Now, there's apps now. You can go online. You could do the American College of Cardiology has one. You could actually plug in your numbers, and you could actually see what is your risk of your 10-year risk of developing a heart problem. We assume if you're over 79 years of age, your risk is greater than 10% right there. So the formula is only really good for adults less than 79 years of age. If you look at the current literature, if you're over 79, we assume that your risk is already greater than 10% to develop risk, cardiac disease. And we immediately want to treat that for that reason. So, our threshold for medications, if you're above 79 years of age, is 130. So if you're above 130, we're going to want to treat it with medications. And that's for that reason, because we already know your risk is high. And if we can control that blood pressure, then the subsequent complications of hypertension we can control. So when you hear that term hypertension and high blood pressure, they're pretty much one and the same, but they can function a little different. And let me give you an example. High blood pressure can be transient. Things can, just like I said, you come to the doctor's office, your pressure goes up. Hypertension, by definition, is a chronic illness. So by chronic means it's always elevated. So when we know it's always elevated, we can say, okay, this is not just a transient event. something happened that may have plucked somebody's nerves or whatever, or scared somebody, but it's a chronic illness that is there all the time. So, and I'll give you another example, and I always like to use this example. Say you're home and you're minding your own business, you get a phone call. And the person on the other line says, Mr. Such and Such, this is Sam Smith from the IRS. We've been reviewing your records and we found you owe us $100,000 and you don't pay it by tomorrow, you're going to go to jail. Well, let me check your blood pressure 5 minutes after that and see what it is. We say that because when you think about it, that is that stressful situation of that phone call, or worse yet, and God forbid, if you hear somebody got in an accident, one of your family members, and I check your pressure then, it's going to be high in all likelihood because of the circumstances in which this occurred. Adrenaline levels start to rise, blood pressure is going to start to rise, but that could be only transient. So I look at high blood pressure as just a potential transient issue, even though people use it interchangeably. But the term hypertension is chronic. That means you have it there all the time. So that is how we look at hypertension and look at high blood pressure, even though people do use them interchangeably. But we do try to get those numbers down, because if you think about what does hypertension cause, we talked about the stroke risk. We talked about heart attacks, but it can also do, hypertension can lead to heart rhythm problems such as atrial fibrillation. I don't know if you've heard that term before, but that's a heart rhythm problem in the top chamber of your heart. Those with hypertension have high risk for that. You could also develop kidney failure. So if you go to any dialysis center in Hampton Roads, I guarantee you 95%, if not higher, is going to be African American in the dialysis centers. Why is that? Because of these chronic illnesses, hypertension, diabetes, which are the top two that are left and go untreated. And the hardest thing in my job is to try to convince somebody of these potential long-term complications and try to get people to stamp it out now, as opposed to waiting until they go on a dialysis machine. Because I know, listen, everybody's busy. We don't want to spend 4 hours sitting in a dialysis chair 3 days a week if we don't have to. And you don't, because again, a lot of these things are preventable, but it takes people really taking the time and effort to make sure they see their doctor and to address the things that are brought up in those visits. So we talked about this issue of hypertension. Now let's dig a little deeper. How do we recommend treatment? So you have two forms of treatment. You have primary prevention treatments or secondary prevention treatments. Primary prevention is when you don't have any known cardiovascular risk. You haven't had a stroke, haven't had a heart attack, no issues of heart failure, nothing. But you do a 10-year risk assessment and it's greater than 10%. And your blood pressure is greater than 130/80. In those people, we would typically recommend medications and lifestyle. If you have known heart disease and your blood pressure is greater than 130/80, I don't need a risk assessment. You need medications and lifestyle change. And people ask me, well, can I ever get off medicine? But yeah, you can potentially, but you got to do the lifestyle stuff. If you're way overweight, you have to get the weight down. If you're eating at McDonald's every day, you got to stop that, because those things, depending on what you're consuming and the salt content in the food, can really impact blood pressures. So when people ask me about stopping medicine, I'm like, yeah, anything's possible, but you got to put the time and effort in to do it. And that's what it's going to take for any time you're doing anything, is you have to put in the work. The doctors can help, but it really takes you doing it as well. One of the funniest things when I have a patient that say, I hear them talking and they'll talk to me about their heart or whatever issue, and they'll fuss about their diabetes, and they'll say, my doctor's not getting my blood sugar down. And I'm looking at them, and they're 150 pounds overweight, and they were just eating at Wendy's. And I'm like, but hold up, time out. What are you doing to help the situation? Walk me through your process, that what you're doing, because the doc can only do what he can do. He can give you all the tools, but it takes some effort on your part to do the things you need to do. You have to own up to your responsibility. It can't be that doctor getting this down. You want them to work around what you're doing. But if you're gorging out on things all the time, they can't work around that, because what happens when you stop gorging? And next thing you know, your blood sugar drops to 0, because all of a sudden all the insulin they would give you is catching up with you. So it really has to be a team effort to really do it and do it right. So now, one of the things with, I would say this, say your 10-year risk assessment is less than 10% and your pressures are 130. Well, we're not going to recommend medications for that. Say if it's 134, we're going to recommend more lifestyle. But if you have known cardiovascular disease, and we talked about this on the earlier slide, we're going to automatically want to treat if your pressure is greater than 130. So if it's 140, the same difference. But if your 10-year risk is less than 10% and your pressures are greater than 140, then we're going to want to do both medication and lifestyle. But if your blood pressure is in the mid 130s or mid 80s and you have a 10-year risk less than 10%, we're going to recommend just lifestyle change. And we'll talk about that in a second. But what are those lifestyle changes? Well, weight reduction, activity or exercise, and sodium restriction. And we'll talk about it in a minute. But look at this slide. I want you to see if we can get your hypertension to goal. We're going to reduce your risk of heart failure by 50% by just getting your pressure controlled. We'll decrease your stroke risk by 35 to 40%, heart attack risk by 20 to 25%, and kidney failure risk, which I don't have on this slide, but that will be reduced by 40% if we can treat the blood pressure to goal. And we want to get those numbers down to a more controlled range. So if somebody says to you, they come in with a pressure of 150 over 90, and in that, you say, listen, your pressure is high. Oh, that's good for me. And I get that a lot too. I'm like, no, that's not good for you. That's not good for anybody. Well, you should have seen it last week. It was 190. I said, well, don't be proud of the fact it was 190. I said, it's not. I said, I'm glad it's 150 versus 190, but your risk is still high. We have to get your pressure to goal in order to reduce that risk. And I guarantee when I hear stroke alert at Norfolk General Hospital, characteristically, when I see that, if I'm involved in that case, their blood pressures are characteristically between 140 and 160. Characteristically. It's not these high numbers that you might think they would be. The numbers are not really that high. But we do know that stroke risk goes up. So that's why we're pushed so hard to get your pressures controlled, because we have data and information that says that if we can get them controlled, we can reduce that risk. If we can reduce that risk, that keeps you alive. So what's better than that? Is keep you around. So we want you around for your families. We want you around for your coworkers and your friends and the people that love you and want to see you around. So we talked about this lifestyle thing. So if we do want to change the lifestyle, let me kind of give you a sense of how exercise and change the lifestyle can help. So if you start to lose weight, now if you're already rail thin, I'm not talking about that, but if you're overweight and you can lose 8 pounds of weight, can equate to a drop of almost 5 points in your systolic blood pressure and 3.5 points in your diastolic. So that's just losing weight alone. So if your pressures are 140 and I get you on losing weight, you can drop that pressure down to 135 just on weight loss alone. Now, say we get your sodium content, and I'm going to tell you, this is tough for most people, but this is the reality. The recommendations, if you have hypertension, is get your daily sodium intake less than 1,500 milligrams. A teaspoon of salt is 2,300. A teaspoon of salt, 2,300 milligrams. So you're talking about less than that. Now, a lot of people will say to me, but doc, I don't add any salt to my food. I'm like, yeah, but what are you eating though? If you're eating canned goods, typically they're going to have a lot of sodium in it. So you have to look at your labels on your foods to make sure that your choices are adequate, that your choices are good for what you're trying to achieve. A lot of times people will get things out, you buy things out in the stores, what sells in America is salt, fat, and sugar. That's what people want. So they're going to give it to you because they're trying to sell what they're trying to sell. So a lot of times people will go, well, I go get it, I get these deli meats. Well, them deli meats have a lot of sodium in it characteristically because, that's what they use for preservatives. So don't think and don't be fooled by the term low sodium. The question is, what does that mean? What's low? Just like you have to take it to context, what that actually means. Because really a lot of that's marketing. Because say a package has 2 grams of sodium in it. Well, if I have a package that has 1,900 milligrams of sodium, that's only 100 milligrams less than 2,000, but it's lower sodium than what was in the original package. So I can say low sodium, but that doesn't mean it's really low. You have to look at what that label says, and that will really help to identify, because you have to add this stuff up all day long. Each thing you put in your mouth, you think about it, has a value of something. It is caloric value, some type of, fat value, sodium value. You have to know what that is so you can make sure you keep track of that. Having said that, if you can do this daily sodium drop, you can drop your pressure another 3 to 10 points drop. So we're talking between the weight loss, 4 millimeters of mercury, another 3 to 10. So that's almost 14 right there, just on weight loss and sodium restriction. And then let's add exercise to it. What are the standard exercise? Either 40 minutes 4 days a week or 30 minutes 5 days a week. And you could just go walking. You don't even have to get on anybody's treadmill or get on anybody's bike. But if you can go out and walk, and walk with a purpose. I don't mean going out snail pace walking, but true walking that you're doing consistently. I'll get people to say, well, I walk and work all day long. And I'm like, yeah, but that's a lot of start and stopping. You're not getting your heart rate up long enough for that exercise to make an impact. So you want to do consistent walking if you can. People may tell me, well, my back hurts, or I have back problems, I have knee problems. Then find yourself a good swimming pool and get in a swimming pool and walk in that water and go back and forth on the shallow end. That's low impact on your joints, but it takes a lot of work to walk through water. So you'll get the exercise benefit without the strain on your back or your joints. But looking at this exercise regimen can drop your blood pressure another 4 to 9 points. Decreasing your alcohol consumption can drop it another 2 to 4 points. So all this is additive. So you can look at almost potentially a 20-point drop in your blood pressure just on lifestyle change. The biggest problem is trying to get people to do it because nobody wants to do it. That's the biggest problem I run into, is trying to get somebody to actually follow those instructions. And it's not easy. I'm not going to listen, the one thing I would tell people, honestly, it's hard to drop your sodium content that low. I came up in a family that was eating fatback and bacon, and sausage and all this other stuff. So it's hard to change that if you've been doing this all your life. But you got to look at the benefits, and then you have to say, okay, how do I make this change? I have to find another form of seasoning that will give me the flavor I'm looking for without the detriment of what sodium can do. One of the things in my church, I mentioned I'm a deacon at First Baptist Butte Street in Norfolk. My foundation, we did some partner with my church, and we did a couple of community, kind of gardens, but it was more of a community harvest, I'll put it, where I contracted with a company or with a group of African American farmers up in Charlottesville area, and we just had a farmer's market, so to speak. So I had him bring down fruits and vegetables that he was growing, he and his team of farmers. And we would have vendors come out and selling some of their goods and services they had. But there was one in particular, a young lady that would sell these seasonings that were sodium free, but she really had a good mix of seasonings. And my wife took that and actually did cook some collard greens. That was some of the best collard greens I ever had in my life. And that wasn't a tap of sodium in any of them. But the benefit that we got, or that I got, and of course I asked her, I said, what'd you do? And she was like, I don't know. I was just trying different stuff and wanted to see what happened. I was like, listen, this ain't helping because now I'm going to want this some more. And you're telling me it's sodium free, tastes great. Now you don't remember how you did it. So I couldn't say too much because she was trying, and she came up with this fabulous regimen of seasoning she did. And I told her, I said, you're going to have to figure out what you did. And we need to do that again, because if we can let people see how good this stuff can be without salt, I think we can really make some impact on getting people in the healthiest place. So as soon as she gets back with me, and I will pass this on, because I think it would be great for you to know that, because they were the best collard greens I ever had in my life. And it was salt-free completely. No fat back, no turkey necks, no nothing. Whatever she did, and I'll find out and make sure you know, but I'm bringing that up to say that you can impact your life, and it still could be good, but yet without the detriment of what the lifestyle can lead. So what are those targets we talked about before? If you have hypertension or you're diabetic, you want to get these risk factors down. You want to target that pressure. If it's greater than 140/90, you want to target it. If you have already have disease, if you're 149, we definitely need to target it. But if you have no heart disease at all, and your risk is less than 10%, then of course we want to start getting that pressure controlled. So if you're over 140, over 90, we need to get it down, period. But if you're greater than 130, because our target is less than 130/80, if we can get you there, especially if you have a high risk cardiovascular disease or kidney disease. But if you're over 140, we got to target it down and get it down. If you're in the 130s, but your 10-year risk assessment is less than 10%, then we go with the lifestyle. But if it's greater than 10%, then we need to get that pressure down. And that's really kind of what the recommendations are. So I want to go a little bit about clinical signs and symptoms, because I want to give you guys a chance to ask questions. So when we think about those, so you got these risk factors, and say you've ignored them. Now you're running into an issue where you have symptoms. So say you have angina or angina, people say it differently, chest discomfort with activity or rest. That's the standard fare. And to give you a prime example of something to think about, analogy. Say you're in your car and you have a partially clogged fuel line going to your carburetor. So if I turn my car engine on and I'm sitting there idling, I'm waiting for somebody to come to the car, but I'm not burning much gas. I'm burning some, but not much. So I say I go into a residential section. I'm going about 20, 25 miles an hour. A main street going up to 30, 35. Highway going up to 45, 50, and then the subsequent interstate. I have to push my foot on the accelerator to get more gas at that carburetor to fire my pistons. Say I have a partially clogged fuel line. That's almost like a partially clogged coronary artery. So if I'm going slow distances or slow speeds, I may be totally fine. I start speeding my walk up. If I surpass what amount of blood flow can get to that part of my heart, I'm going to start to sputter, just like your car will. So when you hear the term angina, typically that's described as a chest tightness or squeezing sensation in the chest that's made worse with activity, gets better with rest. So that's kind of standardly how that works. Now, some people, if they have unstable angina, they will have chest discomfort at rest too. But the standard stable angina is if you walk a certain distance, start having chest discomfort, you stop, it goes away. Same thing when it comes down to shortness of breath. Now, I want to talk a little bit about shortness of breath, because I get a lot of people think shortness of breath means you have to be gasping for air. That's not the definition of shortness of breath. Shortness of breath is anytime you are aware of your breathing, that is considered shortness of breath. Now, there are degrees. It could be a little bit, it could be a modest amount, or it could be a lot. Think about that aspect of when you're doing something. Say like you're just sitting around. You're sitting here listening to me, probably bored out your mind. Do you think about what you're breathing? You don't characteristically think about it, you just breathe. So you're not really aware of that breathing. Now, if I put you on a treadmill for a while, you're going to start getting winded over time because I'm putting you through something. That being aware of your breathing is considered shortness of breath. Now, the question just becomes, is it normal or abnormal? Because if you're on a treadmill, I expect you to get winded after a while. You walked up several flights of steps, I expect you to get short of breath. The question is it different from what your standard has been? In other words, say I used to be able to walk a mile with no problem. Now I can only walk a couple of blocks and I'm getting winded. That's a change. There's something that happened that has created that change. That's for people like me to figure out. is that something going on, that why that change occurred? And it could be different things. It may be heart related, it may not be, but it needs to be brought to our attention so we can kind of figure that out. Decreased exercise tolerance, that's part of that same package. If you used to be able to walk further and now you can't, when you try to do it, you just can't get that energy up to do it. That is considered some type of decreased exercise tolerance. That could be a sign of heart problems. It may not be. Could be other things. Could be you just never exercised before. You laid up somewhere and just hadn't got a chance to do it. Or if you've been, kind of say you had an accident and you couldn't get up and do anything at all. Then all of a sudden, a month later, you've recuperated, you start walking, you're going to get tired faster, not because of a heart problem, but because you hadn't done anything for a month. Palpitations or feeling like your heart flutters or races, that could be a sign of heart disease, may not be. Blackout spells. If you black it out, that could be a sign of heart disease. May not be, but it could be. These are things why it's important, because then you bring it up to your doctor and we could then figure out how do we address it. And this is how we address it. We have to do what we call a pretest probability. We look at your history, your physical exam findings, family history, risk factors. And we have to say, okay, we look at what is our pretest probability that this person has a heart problem. Is it low? Is it intermediate? Or is it high? And based on that helps us to determine what we need to do to sort this out. People with low risk of heart problems, characteristically, we're not going to do much of anything depending on the situation. We know your risk is low. If it's intermediate, we typically would do things like non-invasive testing, stress testing. We put people on treadmills, other forms of testing where it's not invasive, because we think you might have a problem, but your risks are not that high, they're not that low. It's kind of in the middle. Now, people at high risk, sometimes we go straight to invasive testing because we know your risk is high. If I have somebody who has hypertension, they're diabetic, they smoke like a chimney, they got cholesterol of 400, and their father died of a heart attack when they were 40, and you come in with chest pain, and it sounds like a heart problem based on what I hear, the question is, what's the best test? If I do a stress test and that stress test is normal, will I believe it? Because you can have a falsely positive stress test, and I can have a falsely negative stress test, meaning person could still have blockages, but the test look normal. And I can have somebody with a stress test that looks positive and they have no heart problems. So I have to ask myself, how much do I believe that test result? So if I believe it, then okay, I'm fine. But if I don't believe it, I know your risk is super high. I'm not going to waste your time with a stress test when I know goodness well, I know that there's a strong likelihood you have heart problems. I am going to recommend invasive testing, because if the test is negative, I'm still going to be worried about that patient, because I'm saying it's just no way I can believe they don't have a heart problem. It sounds like it. It looks like it. It walks like it. It talks like it. I'm going to go all out, because I know my job is to keep people alive, and to, at least with God's help, of course, keep people alive and healthy. So that's kind of how we assign risk. So once we know the risk, then we have to either look at stress testing, cardiac catheterizations, or just medications. Do we need stents? Do we need bypass surgery? The one thing that I want to make sure I share with you about heart problems, every heart problem does not need to be fixed, meaning I can have a blockage in somebody's heart that's 70 or 80%, but it doesn't mean that that blockage needs to be fixed with a stent or bypass surgery. Why do I say that? Because if you look at the data in the literature, it does not, the indication to put in a stent in somebody's heart is symptoms you can't control with medication. And a lot of people think, well, the doctor saved my life because he put 3 stents in my heart. That didn't save your life unless you're having an acute heart attack. If you're having an acute heart attack, that's different. But if somebody has blockages in their heart, but they're totally asymptomatic, can exercise and do anything they want to do, there's not a stitch of data anywhere in the literature that says you have to get those arteries fixed. Typically, what we'll do is we'll manage the risk factors, make sure your blood pressure is controlled, cholesterol levels are controlled. If you're smoking, get them off cigarettes. If you're diabetic, we go get your blood sugars down. These are the things that are going to help save your life. It's not doing a stent or doing a bypass operation. A lot of people think that's the case, but if you look at any of the literature, even our guidelines, we're bounded by guidelines or treatment by the American College of Cardiology. And if you look at any of those guidelines and they're published in the literature, this does not say that you have to fix a blockage because it's there. No such thing. That's why I'm not a big fan of these vans that go around, get all these tests for $99. I mean, personally, I just think it's a scam. And I say that only because if you don't have the full gamut of understanding the medical condition that goes with those test results, what do they really mean? Just because you have, it can help you a little bit assigning risk, but without a doctor's help that really can help guide you, I personally am not an advocate for just getting routine stress tests or routine testing of any kind, because there's no data to support it in the literature. So I want to make sure you're clear about that. So if you look at, this is a blockage here, this is a cardiac cath film. So we shoot dye in coronary arteries and we look on the x-ray. All these little narrowings here are not significant, but this is probably about 90% blockage here. And that's how we do those catheterizations to tell. And bypass surgery, essentially, we take vein out of a leg, tag one into the aorta and tag in the vessel past the blockage. So that's creating like an alternative roadmap where you're getting adequate blood flow. So that's essentially what bypass surgery is. So, and to finalize things, how do we really deal with this? Well, we want to prevent. We want to have you see your doctor, regular checkups. We want to watch your weight, get your optimal weight. The DASH diet and Mediterranean diets are the only diets that have been shown to reduce cardiovascular morbidity and mortality. So when we say morbidity, we mean disease that happens as a result. Mortality means death. So the DASH diet and Mediterranean diets are the only ones that have been shown to reduce cardiovascular morbidity and mortality. So you want to manage your cholesterol, you want to get your pressures controlled. If you're diabetic, you may have heard the term hemoglobin A1C. That's a marker of your average blood sugar. We want to get that less than 7 to manage your risk factors better. And then exercise either 5 days times a week, 30 minutes, or 4 times a week, 40 minutes, some type of cardiopulmonary work, which would be things like walking. And you can do that, and it's more than satisfactory. If you rather run, if you rather be on a bike, that's fine. But I don't want people to think they have to do that in order to get the best risk of reduction. If just walking with a purpose can do just as much. Of course, if you're smoking, we want you to quit. Your weight's up, we want you to get down. I want to finalize things with statin drugs. Now, I know a lot of people think the medicines are the enemy of the people, but it's really not. If you have a high cholesterol level, we need to get your cholesterol levels down. And using statin drugs such as Lipitor or rosuvastatin, which is Crestor, has been shown to reduce your risk significantly. So I really want to try to make sure I say that so people don't listen to Cousin Fred, who doesn't know anything about medicine, that tells you, don't take this because Joe Blow died from it a month ago. Cousin Fred doesn't have the medical background to really help you make the best decisions. I'm not saying don't ever hear anything Cousin Fred has to say, but Cousin Fred doesn't have the medical background. When we were dealing with COVID, and everybody was all anti-vaccine, and people would debate points with me saying, I did my research, it shows X. I said, yeah, but you don't know medicine. It's one thing. That's like me telling you how to finance your money. I am not a banker. I don't do investments I don't do a ton of them. I went to school all my life and learned how to be a doctor. And I think I do it pretty well. I'm not perfect, but I try my best to listen, learn, and use that information to help me be a better person and a better doctor. In order to do that, I've gained the experience of constant reading, constant learning, and implementation, and then seeing the results of that. People that are just reading something on the internet, that doesn't give you the background to know how to make sense of things. So I'm saying all this to say, if you don't trust your doctor, then get another doctor. But don't let Cousin Fred, who doesn't know medicine, sway you to make a decision that may put you in harm's way. And every time I've seen that happen, I always go to Cousin Fred and I said, listen, let me ask you a question. Since you gave that person that bad advice you just gave them, are you willing to take that person on and take them in your home and take care of them for the rest of their life if your bad advice gets them in trouble. And I just wait for a response. And the answer is going to be no. I'm like, if you're not going to do that, then don't give advice when you're not qualified to give it. I encourage people to question things and don't just take every doctor's word. You have to develop a relationship with your doctor if you have one. If you don't have the relationship, I always tell people, consider, is that the right person for you? Everybody's not right for everybody. But, if you kind of have an established relationship and you're really in that place where you can trust that doctor's opinion, at least you'll have the experience and the know-how behind that doctor's background to help you make the best decision. And the way I typically do is I tell people, listen, this is the issue. These are your options. You can do this, you can do this, you can do this. Pros and cons of each one, and let that patient make the best informed decision. I will always tell people, if it were me, or what I would say based on the data in the literature, this is your best option. However, if you feel differently, these are your issues, these are your options you can follow. So I think that has proven good for me, giving these options to people, because I want them to feel that it's not just my way or the highway. It's not just me telling you this, but I'm giving you several things to consider. And I can tell you based on the literature, which one's best, which one has got the most traction, which one's modest. And there are some options I say, like doing nothing. I say, no, there are some situations where I think doing nothing is a bad idea. But I would tell the patient that. So I don't agree with it, but it is an option. And that way they have all the things on the plate and they can make the best decision. So I'm going to skip this part here because, again, we talked about this. I do want to talk a little bit about aspirin real quick, and that'd be my final statement. So a lot of people ask me, aspirin, should they take aspirin? You may have seen some things in the literature about aspirin, and kind of it's been somewhat of a no-no. And I won't say that. Aspirin still has its place. But if you really go back in the literature, aspirin was never designed as a primary preventative tool. And when I say that, what I mean by that is when you think about, say, somebody says, I want to never have a heart attack, so I'm going to take an aspirin a day and that'll help keep me from having a heart attack. Well, the problem is there's no data to support that in the literature. There's never been any studies that looked at it as a primary preventative tool. It's always been secondary prevention. Those who've had heart attacks, those who had strokes, yes, aspirin can help prevent that. Now, you got to weigh out risk benefit. Initially, with the 325 milligram aspirin, we were seeing more gastrointestinal bleeding problems. So the swayed away from that, went down to 81 milligrams, and that was recommended for everybody who's on aspirin. Now, is it good for primary prevention? No. Do we use it all the time for secondary? No, because it depends on the scenario. It depends on the patient's age or other medical conditions, because aspirin essentially is a salicylic acid. So it's an acid that can tear up your stomach. So, even the coated aspirin, depending on when it dissolves, if it dissolves too quick and the coating goes away, it still can irritate the stomach. It will be less likely to do so if it's coated, but it doesn't mean it's going to be symptom-free. So you really want to carefully decide if you're going to be on aspirin, that's the right thing for you, and I would get your doctor's advice on that. So in conclusion, I wanted to throw out, when we talk about heart disease, we want to define it, which we say anything that affects the heart or the great vessels. So if you have a leg artery problem, that's a form of heart disease. You have a stroke, that's a form of heart disease. Coronary artery disease is a form of heart disease. We talked a little bit about pathophysiology. What are the things that can lead to that? So I wanted to make sure you understand the hypertension, the diabetes, high cholesterol, being overweight or obese, family history, smokers. They are all relative risks that can lead to heart problems. We talked a little bit about clinical signs and symptoms and how we diagnose it. And, again, chest discomfort describes a tightness, squeezing sensation mid-chest, starts with activity, goes away with rest, is deemed a potential angina or a symptom that could be a form of heart problems. And I always say could be because you can have chest tightness from other things. Asthmatics can get chest tightness. People with reflux problems can get chest tightness. has nothing to do with the heart. That's where we come in. Symptoms, the diagnosis, how do we do that is all based on your risks, hearing the symptoms, and making up with a clear, definitive diagnosis. And then based on how we make the diagnosis, that's when we get to the treatment. But first and foremost, and primary, is always going to be prevention. We can prevent it from happening in the first place, which I would always rather do. I don't want to wait till the horse gets out the barn. If we have a situation where you have one of these heart conditions and we allow it to occur, there's a high likelihood that you could go on and have a shorter life. And we don't want that. I want people living the best, healthiest, longest life through God's grace and glory. We can do that, but we have to be mindful of asymptomatic diseases that can lead to heart problems. So don't run from the doctor. I don't want you to do that. I don't want you in the doctor's office every 5 seconds either, but I don't want you running from the doctor. I want you to embrace the problem, learn about it, understand it, figure out how you can make it better, and live your best life. So that's essentially my talk for this evening. I thank you for your time.
Dr. Newby, thank you very much. I want to ask the audience if anyone has any questions they want to ask you.
Good evening. This is Jim Denise. Hello, Dr. Newby.
How are you?
I'm good. I do have a question. My husband is an asthmatic, and every year he's hospitalized, and they say it's because he has a heart arrhythmia. And they always think every year, he just got out of the hospital Christmas time. Every year he does this, and then when he takes EKGs, they say his EKGs are a false positive because they did a cardiac on him, catheter, and the guy said, "Oh, you got a false positive." But every EKG he takes comes out that something's going on.
Well, the thing is, it would be hard to say without actually seeing what the issues were. Like, what is it they're seeing when they say like a heart arrhythmia? Are we talking atrial fibrillation or just some skip beats in the heart? Because anytime you have a breathing problem like COPD, a lot of times that taxes the heart because you're struggling to breathe. Now, it's not a direct correlation, but it definitely could be an add-on. So it really kind of depends on what they saw. And the problem what bothers me with doctors now is our communication skills leave something to be desired. I'm not going to lie on that one. You would think in the world of technology and better communicate, but the things you will have better communication, but I feel like it's worse. I always joke with my daughter is 18 and she'll send me a text message. I'm like, what are you trying to say? I mean, it's like, I just know this is kind of how the kids communicate, but I say, English, talk to me and use the King's English. I know what you're trying to say. And I say all that to say that I know this is just the nature of how communication occurs. But I think what I would suggest is next time he has to go in the hospital, hopefully he doesn't have to, but if he does, have them kind of like I detailed some things tonight. When they say something about what the EKG shows, well, why is it okay? If he did a catheterization, you said he had a catheterization that did not show any blockage.
It didn't. The guy came back and he said, "Oh, you got a false positive on that EKG."
So the question becomes is, why do they overreact every time it's the same EKG abnormality? Before they start going off the deep end, time out, Chief. Have you looked at the records and looked at what has transpired before? Because that EKG abnormality could be a reflection of the COPD strain on the heart. Now, again, without seeing it, I don't know, but that is not uncommon to hear that. But the key thing is going to be if he's always going to the hospital, they can't do the exact same workup each and every time. I mean, I'm not saying they shouldn't ignore it either, because every now and then you'll have a situation where the heart was fine 1 minute and is not fine the next minute. So that does happen. But the question is it different from what it was before? Meaning the EKG may be abnormal, but is it the same abnormality that's always there, or is it a different abnormality now? Because that could be different. So, but they need to start sitting down with you guys and map that out, and say, okay, if we're going to be doing all this, okay, we've been through this every year. help me understand what's different now than it was last year. And if they say they ain't look, well, go look first before you have me doing 800 things, because all they're going to do is run your bill up. And I know they're not doing this intentionally, but again, that's the thoroughness that you have to do. You have to say, I'm going to take a thorough approach and make sure I'm doing all that I need to do, but not doing something that's been done 800 times already, because of the same abnormality that always shows up each and every year. And then we go through this $1 million workup that's not helping your husband at all.
Gotcha. Okay.
So
thank you.
I would push them to sit down with you and map it out so you know. I mean, you're not going to know all the details, but at least you say, write it out for me so I can keep this with me. So next year I can bring the same paper back and we could talk about this next time you want to do the $8 million workup.
Gotcha. Thank you.
Thank you for that question, Denise. Does anyone else have a question for Dr. Newby?
Don't everybody jump out at the same time now.
Hi, this is Jimmy Vaughn. I do have a question, Doc. Well, a comment also. I have some of those things that you talk about, diabetes and all that, but I also have a left bundle branch block. And listening to what Denise said, my cardiologist says it's going to always show up on my EKG. So when I go other places, if I go to other people, like let's say I go to a patient first or something, if they're going to do an EKG, let them know that I have that, so they won't say, oh, I got to send you to the emergency room. So I like what you said. It is good to know what you have, because so that always shows up. And they compare the EKG, you know, each time that I get one, they compare to see if there's a change from the other time.
The other thing you may want to do is either get a copy of your EKG or take a picture of it.
Oh, that's a good idea. Thank you.
So that way, when you go to these, patient first, because this is a problem with patient first, they really don't know heart stuff at all. So I mean, they know some basics, but they're not going to know like the details. So they're going to panic quickly, and it's typical patient first scenario. You go in there with chest pain, they're going to do an EKG and send you to the emergency room. Standard. And I tell people, don't waste your time with urgent care with chest pain, because they're going to do the same thing. They go, unless you're like 10 years old with no other issues, they're going to do an EKG and send you to the emergency room. So, that's the thing. But if you have your EKG with you, it could be either a picture of it or just if you have a copy of it that you keep with you at all times when you know you're going to be someplace that you may have to go to an urgent care, what have you. That way they'll see it. You can just show it to them, and especially if it's 10 years old, it's the same left bundle branch block. And that is true. Now, the reason that becomes an issue is people who have a left bundle branch block. There is a 30% incidence of people who have that will have heart disease. Now, that's why they do all the work they did with you already. So you're just not, you're the 70% that doesn't have a heart problem, but they don't know that.
Right.
So, they're going to go and I wouldn't say and trust me, I tell people all the time, when in doubt, I'd rather you send a person to the emergency room, because if you choose not to do it and something happens to them, you'll live to regret it. But for us as cardiologists, we deal with this all the time. So we know. And just so you know what a left bundle branch block is, all that is when your heart fires electrical circuits, all it's doing is taking a different path to get from point A to point B. So in other words, how it normally would go, it may take a path. It would be like, say, if you're going to Virginia Beach, and some people would go to Virginia Beach using 264. Some people may go using Virginia Beach Boulevard all the way out to the beach. So a left bundle branch block is like you going to Virginia Beach on Virginia Beach Boulevard. It's going to take longer for you to get there, but you're going to get there. And that's why it gets wide and looks the way it does, because of the time it takes to get from point A to point B. It gets there, but just takes a little longer.
Okay. The other thing real quick is that I also do have reflux. And so in the past, because I do have diabetes and I do have hypertension, but it's under good control now, is if I go to the hospital, they usually keep me that 24 hours or 48 hours. And it's like, what is that blood test that they do to make sure you don't get a heart attack? Yes.
troponin.
So they usually do those workups on me because of those risk factors that you mentioned. So it was a very good presentation, and I thank you for sharing with us.
Well, thank you very much. And I saw somebody ask a question about what diet should people follow. I think that it's based on a couple of different things. What's your medical condition? And your situation. Of course, if you have heart disease or potential for heart disease, the Mediterranean diet is the best for preventative. That's where you use certain types of fats, like olive oil, and certain types of fats that are less problematic, certain types of carbohydrates that are less problematic, than certain other things. You want to follow whatever diet is going to get you in your best position. If you have hypertension, DASH diet because of the low sodium content. So it just depends on the individual person, what their status is, helps to decide what's the best diet. One of the things you can also look up, if you look up the U.S. News and World Reports, every year they do this article called The Best Diets in America, like 31 Best Diets in America, something like that. But if you look it up online, it's usually the first one or two things that pop up on Google. And you can look through that. And one thing I like about that is it highlights all these different diets, pros and cons, risk benefits. And it really says like which one you lose the most weight on. So it depends on your goal you're trying to do, but at least it'll give you an opportunity to look and see all these different types of diets or lifestyle changes that need to be made or can be made. And then you can see which one might be the best for you because they give little snippets of each one. And then you can say, okay, I think I could do this diet. And then you do your research on that particular diet, but at least gives you an overview and gives you an opportunity to really look at the different ones. Because I tell people, tell me all the time, give me a diet. And I'm like, I can give you one, but that may not be one you feel comfortable following, may not be in your best interest based on your medical condition. So I think I can help guide you if we know what the issues are, but I think you really need to see what type of diet can you follow. Because some people, like I can do low carbohydrate better than I can other types of diets, but that's a me thing. So everybody's a little different with that. So I just want to bring that up.
Thank you.
You're quite welcome.
Anyone else have a question for Dr. Newby? Okay, well, Dr. Newby, I want to thank you again on behalf of Le Gym Incorporated. And I want to thank my co-chair with me, Charlena Hadi. She's on tonight. And I want to thank all of you who took the time out to sit in with us. Dr. Newby, you've done a fantastic job again. And I can't stop thanking you for coming back to us again. Charlena and I had the opportunity to see you last year when you did a presentation over at the Basilica of St. Mary's.
Oh, yeah.
So we were there and we saw that.
Well, thank you. They already contacted me about coming there again, I think in May. So I'll be back there again.
Yes. Okay. Ladies and guests, thank you very much for being with us this evening. Have a good evening, and I'm pretty sure that Dr. Newby will want to get home and get some rest.
Thank you. I still got a lot of work to do.
Okay. Thank you, everyone. And thank you, Tech Team, for your help this evening.
Thank you very much.
All right, we're going to close out now. Thank you so much.